For those who just joined, we're just waiting for a few more minutes.
Okay, sounds like we think we have critical mass. Hello, hello, and welcome. So thank you for joining. Always the same disclosure. This meeting is being live streamed and recorded. I'm excited to be here with you after a little break, and we're going to dive into some subcommittee work. We're going to get trained up today. So we need to, there's going to be we're going to get to hear from our licensing boards. And so it's an opportunity for us to learn. We'll take a break in the afternoon, get some carbs, because it's going to be opportunity there'll be a lot of listening, but it's worth our time because we have an opportunity to learn about, how we could enroll people into the workforce. So we're going to have presentations from the four boards that oversee the different licensing processes that we're kind of most focused on, and how their work aligns with the HEC assessment. And then what we're going to do is we're going to have people do a presentation on how their board works, and then we'll have question and answer time after each section. First, we're going to have the Mental Health Addiction Certification Board, MACBO, by Van and Eric going to present. Then we'll follow up with Todd Yunkin from the Mental Health Regulatory Agency, and Todd's going to have somebody co-present with him. We're going to take a 15-minute break. If we're running a little longer, we'll shorten the break. And then we'll do Ray Miller with the Board of Licensed Social Workers, and then followed up by the Oregon State Board of Nursing with Rachel Pruzak. So we've got everybody, we've got all of the folks, and it's going to be super exciting. And before I dive into the agenda, so I wanted to I was asked to kind of provide a little bit more information on, so in addition to chairing these meetings, I've been out meeting face-to-face with providers in the community all over the state. And so that was work that I was doing with the governor, but I've now, since the starting of the Behavioral Health Council, have been to 27 different places. And or met with 20 different groups. And it's been an opportunity to kind of understand how people are doing better or worse around staffing crises, how people are using resources wisely, some of the challenges that people are facing in different rural areas, and just how we do the work. And it's been incredibly helpful. Like I said, it's been 23 field visits. I've had the opportunity to meet with some of our folks that are on the council and their organizations in particular. Janie Gluckson of MHAAO, which is soon to be the peer company. That was just an incredible visit. Had the opportunity to see Julia Mines of Miracles Club and Shira from Clatsop Behavioral Health. All of these folks are doing really incredible work, innovating and doing savvy, smart things to work with the resources that they have. It's my hope that I can share a little bit with you what I've learned from each of these visits as we go along, and have been asked to bring that up from our vice chairs. Also had an opportunity to meet with Robin Sansing, who helped organize a meeting of educators at Southern University, and being able to talk with a cross-disciplinary team about educating the behavioral health workforce. I got to learn a little bit more about the youth pipeline by visiting Lines for Life. And it's super exciting with the youth peer work, because you're not only delivering critical services for peers, but you're also acclimating those folks to be behavioral health providers themselves, and they come in ready to go. They've had the conversations, they know what this is like. It is we are doing both things at the same time. Also had the opportunity to visit the CTE program in Salem, where high school students are graduating equipped with certifications to enter the field. So exciting to see young people getting to practice, getting to see what they have rooms set up like clinical spaces and just what it means to practice this and work with other young people and get those skills to where the first time that they ever go into the field, they go in ready. And so that's been really exciting. I was able to do a listening session with rural providers in Southern Oregon. It was one of the first things that we did, and it was so some of our members are here today. And that was a great kickoff to start these conversations, specifically around some of the problems that folks face, particularly in rural areas. And we saw a lot of, it was really important that it validated much of the discussion that had been happening in the Health Talent Report, right? Many of the conversations were these were things that had been discussed, but this is how you find out is you're testing that against actual people in the field. And we learned a lot in those conversations. And then recently, I was on a trip to Eugene, and I visited with Looking Glass. It's a psychiatric subacute facility for youth, and we've talked about the need for more providers in the child spaces, and this was the first time I'd been to a psychiatric subacute youth facility, not my first a psychiatric facility, and I learned a lot about the regulatory struggles that folks are having in that space, and some of the challenges people are having around rules around restraints that can be unclear when young people are struggling with unsafe behaviors, and that it can create some challenges for the staff when they're who are trying really hard, but are in a kind of a really difficult regulatory environment. I think we talked about at our last meeting that the governor's office had worked on House Bill 3835, but which was with the System of Care Advisory Council. And I bring this up just because it was something that was playing out in the field in real time, and is something that the youth behavioral health providers are continuing to monitor. Only because it's really critical in keeping clients safe. And a lot of times with young people, we're looking at folks who are there with self-harm behaviors that were pretty significant. And one of the things that the providers were talking about is having folks in the field for 15 years and then end up leaving because they were nervous about feeling like they were being criminalized. And a story that stuck with me is, one of them talked about how if there were to be a complaint, that could create a situation where then as an adult, they wouldn't be able to like coach a child's little league team. And it really brought home for me some of the things that folks are living with while they're just trying to do the work. They also have an incredible team that has been there for a very long time and is deeply invested in the health kids. And talked about the importance of making sure that we can provide help with the cost of education to get people into the workforce, which was a huge thing for the youth providers. But they having staff that had been there for everything from just some new, but mostly people who had been there a bulk of their career. And so that was a great opportunity to get to be in one of those spaces. Let's see. And then I would just the last thing is we also got to go to Peace Health in Eugene. Learned a lot about how they manage turnover among the nursing staff, and some things that they've been able to do that have been really robust around their internship. They talked about the challenges, as many of you have struggled with, of discharging homeless patients to the street, and just the moral injury as well as the logistic challenges, and how counterproductive that is when we work so hard to get someone healthy. So there was also a convening that same day of behavioral health stakeholders at the county level, and Lane County is just doing really exciting work within their county with different providers to talk a little bit about what they can do. An example is there was a group that started a QMHA certification program working directly with Lane Community College. So now they realized that they were only a couple of kind of key education indicators off. And by being able to then get those, they could graduate people right into a QMH path and then off to the workforce they go. And so that was just really exciting. And And then the only thing, and then I get to stop talking, which is always my favorite part. Uh, I just wanted to acknowledge that it's been a tough week when we think about the federal cuts. Um, and I know that you're all looking at it and reading about it and having the consternation that I am having. And and that we all understand that these are some of our most vulnerable folks that rely on Medicaid services, as well as also the supportive services like food stamps that directly support that population as well. That has been, for folks who don't know, is a huge priority for the governor, who's done work on food stamp programs since early career. And so just know that the governor's office is committed to defending Oregonians and working with state agencies and community partners to minimize the impacts of cuts as much as possible for everyday Oregonians. This is something that they're getting handed, but just I'm sure you've seen the stories in the paper. There's a lot to know. There's a lot to get rolled out. It will take a while. I just felt like I wanted to acknowledge that and just know that the administration is committed to protecting people and trying to minimize as much as I can. And so with that, it's time to move on to the agenda. And if you have questions, raise your hand. You have Chad's email. And I think what we'll and then so Casey is gonna start us off. And I think we'll make up time. Okay, next presentation by Casey Liddell, Senior Behavioral Health Advisor and just general awesome human in the governor's office, to talk a little bit about the work that the Kotek administration started with the licensing boards and how those things work together. Take it away, Casey.
Thank you very much. And yeah, I think I can make us up a couple minutes here as well. Do we have my PowerPoint ready to go? All right, so I just want to do a very brief introduction before our wonderful licensing boards jump in and give you all of the interesting information about what they do and all the work that they have been doing to improve what they do. So go ahead to the next slide. So you're going to be hearing today from the Mental Health and Addiction Certification Board of Oregon, the Mental Health Regulatory Agency, which includes both the Board of Licensed Professional Counselors and Therapists and the Board of Psychology, the Board of Licensed Social Workers, and the Oregon State Board of Nursing. So between these four organizations, they are responsible for the licensing and credentialing of the majority of the behavioral health workforce. There are some other positions that are credentialed through other entities, such as psychiatrists, but this is the vast majority of the workforce that we are looking at when we are talking about the work of this council. Between them, these four boards serve over 170,000 licensed and certified practitioners. Next slide, please. So, as I am sure you all know, behavioral health is a main priority for this administration. You have here the statement that is on the governor's webpage regarding behavioral health, and I pulled out specifically the portion of it that relates to the behavioral health workforce, which states that Oregonians are turned away from treatment and services every day because there is not enough workforce to meet the need. Governor Kotek requested funding to double the current ongoing investment to grow and diversify the behavioral health workforce, and she will also work to streamline and create efficiencies in the licensing and certification process. That's that last line that we're going to be talking more about today. Next slide, please. And just to talk about some of the work that's already been done on this, the administration has been working with our licensing boards to try to identify and meet their needs to better serve the practitioners and the consumers. This includes additional staff that was allocated to the Board of Licensed Social Workers in 2023. There was also a request for a licensing database that would serve both MHRA and BLSW. We requested that funding in the 2025 session. That request was not funded, but they did include a budget note asking for both of those organizations to return to the legislature in the 26th session with additional information about the request. So work on that will be ongoing. And then our licensing boards have just been working diligently to improve their customer service, streamline licensing, and expand access to licenses and credentials. We've been learning a lot about some of the efforts they've already made in the licensing and credentialing subcommittees. But I want to turn the mic over to them because I think they can sort of talk about the work they've been doing and how far we've come and what sort of is still left to do better than I can. So that's my introduction. We're ready to move into the next section.
Thank you. Thank you. Van and Eric, are you ready to go?
We're ready to go. Now, are we sharing or are y'all sharing for the PowerPoint?
I am happy to share if it makes it easier. You are now a co-host, so you can share as well.
Yeah, why don't we share, Eric? Okay. Y'all can see that? All right, so I'm Van Burnham. I'm the executive director of MACBO, and if you've been around long enough, you know us formerly as ACBO. We started back in 1977, and we largely credentialed addiction counselors. But in 2018, we started credentialing QMHAs and Ps, changed our name to MACBO, and within 2 or 3 years, we had more mental health counselors than addiction counselors. So these are some of our certification partnerships. So the ICNRC, that's the company that writes the National Substance Use Disorder exam. It's used in most states around the country. I'm on the board of directors. Eric's on the board of directors for the National Certification Board for Behavioral Health Professionals.
They produce exams for unlicensed mental health workers at the graduate or less level. And currently New York is the newest board, and they're using the same QMHA exams that we use in Oregon.
NAR, so NAR is the National Alliance for Recovery Residences, and a lot of people don't realize this, but we also accredit recovery residences, and we have several hundred houses that are accredited through, I think, 12 or 13 providers. And then we also work with IPGGC, which is the National Gambling organization that does the development of the gambling exam. So these are our staff. So as you'll see, we're relatively small. We have 6 full-time staff, me, Eric, and then we have a director of credentialing, associate director of testing, certification specialist, and Wendy is our newest hire. She's our workforce engagement coordinator. And then we have 2 part-time staff, which makes up about 0.75 FTE total. One would be Karen Willock, who works on ethics, and then Dick Johnson, if y'all know him, he works on the gambling certification. So these are our numbers. So you'll see the annual registrations that would apply to the C80CR or anything that is a -R, and then the exams would apply to the credentials under it. So for example, in the first row, we had 1,353 C80CR registrations last year, and we proctored 535 exams across the 3 different levels of C80C. So you'll see we're quite busy, over 5,000 registrations each year and almost 2,000 total exams between, under 7 FTE.
Anybody have any questions about these numbers or anything? Okay. So these are the varied requirements at each level of certification. And I know that sometimes people look at MACBO and they're like, wow, why is there so many certifications? And it's because largely, most of our workers have less than a graduate degree. And what has been discovered in the addiction field for many decades is that if staff have something to work towards, if they can work towards higher levels of credentialing without having to go back to college and get a graduate degree in order to get ahead, if they can work towards higher levels of credentialing, they're more likely to stay in the field and they earn a little bit more money and it's worthwhile for them. So this has long been known and understood in the addiction field for many, many decades. And this is a system, this multi-level of credentialing for addiction counselors is in virtually every state in America. And so this is something we've well understood. About 10 years ago, Oregon Health Authority contracted with the Farley Research Center out of Colorado. And they wrote a report and they said, you should start certifying QMHAs and you should make multiple levels because this will increase workforce retention. And that's precisely what has happened. Our data analytics over the last 5 years clearly shows that as QMHAs advance in level of certification, they're more likely to renew, they're more likely to stay in the field, and the supervisory competency assessments show that they have increased competencies. So people they naturally want to, move up the career ladder without having to necessarily go and get a graduate degree in order to get ahead in life. So that's one of the main reasons that we have so many levels of certification. And we have varying requirements. I don't want to bore you guys by going through each certification and its requirements, but maybe I'll go over the QMHA and then maybe it'll make it obvious otherwise. But for the QMHA registered intern, we use the existing rules that are in Oregon Administrative Rule and have been there for 30 years. The person has to have a bachelor's degree or equivalency. And for the last 30 years, the OARs have said an equivalency to a bachelor's degree is 3 years of education and relevant experience. Well, first off, people would say, well, that doesn't make sense. A bachelor's degree is 4 years. It's not 3 years. So why would it be 3 years of education and relevant experience? Because it's 3 years of behavioral health education and relevant experience. So if you went and got a bachelor's degree in psychology, 1 year of your psychology bachelor's degree is just gen ed. It's like geometry and algebra. And if you're really old like me, I've been doing this for 40 years now. And believe it or not, I've been evaluating people's transcripts going all the way back to the 1980s. And people on their transcripts used to have badminton and bowling. So only those of you that are a little bit older in the room will know this, but in the United States, back in the 1970s and 80s, almost every university had a bowling alley. So they were in the student union buildings, but most of those bowling alleys are now closed. They're gone. But people actually had that stuff. So that's where they came up. That's where they dreamed up the 3 years of education, because it's 3 years of relevant behavioral health education and experience, minus that 1 year of gen ed that they felt was not really applicable to behavioral health. Okay, so we use those rules. And then for QMHA 1, a person has to have 1,000 supervised clinical hours working in the QMHA competencies. And then for QMHA 2, they have to have 4,000. For QMHA 1, they have to take the National Basic Mental Health Associate Psychometric Exam. And for level 2, they have to take the Advanced Mental Health Associate Psychometric Exam, which focuses more on case management and care coordination and jurisprudence questions. So around like HIPAA and confidentiality and mandatory reporting and things along those lines. So I'm not going to go through all the certifications. I'm just going to cover the QMHA there, just so you get an idea of how the system works and why it is the way that it is. Anybody have any questions about the requirements? Does it sort of make more sense now? Okay.
Yeah, well, hold on. So I think probably one of the important things to note here is that even though there's a lot of credentials, there's a lot of spillover between our credentials. So we try to build a career ladder. And for example, the CRM, there's a 40-hour peer course that could work towards a person's 3-year equivalency for QMHAR, that 40-hour course. It could work towards their CADC1 requirements. Some of their peer work can also, the supervision work can also transfer over to the CADC1. So I don't know if y'all remember, but at the very first meeting when we asked what's our fantasy that we could have, and I said it would be nice to have funding for some sort of career coach that would be able to assess people where they're at. That's kind of what this was about is depending on who you're talking to, you kind of got to figure out where they enter and then where they can go based off their experience. Maybe they've got criminal history, their location. So, and that's one thing that we work really hard at doing is just to make sure we meet people where they're at and we put them on a track that is that's possible so that they can succeed and hopefully be retained in the workforce.
Liz?
Yeah, I know you guys were just going to go over the QMHA, but I just had a question about the QMHP-R and C. Can you explain like the differences and yeah, just kind of the differences through those two?
Okay, so the QMHPR is for individuals that have a graduate degree. Most of the time, they don't qualify for licensing because they don't have a KCREP accredited master's degree. So this might be like people that went through the University of Phoenix. And I don't know if you guys remember, but at one time there was a University of Phoenix, extension college program on every block in America. So lots of people got graduate degrees as master's in psychology degrees, but they don't qualify for licensing, but they can work inside of licensed programs and they don't need to be licensed. So QMHPRs are individuals with graduate degrees in behavioral health. They get registered as interns with us. The intern registration is valid for 2 years. And then they need to present 1,000 supervised clinical experience hours in the QMHP competencies, primary source verified with their clinical supervisor at the COA program. And then they sit for the National Graduate Mental Health Psychometric Exam. And it's a very good exam. We've had people take both the LPC exam and the Graduate Mental Health Psychometric Exam that we offer through NCBBHP. And they've said that they thought that the exam that we use is very pragmatic for community mental health. So the exam covers the top 10 diagnoses in the US Medicaid population. So it's very much a Medicaid-centric graduate mental health exam. Was there anything else, Liz?
No, that was it. Thank you.
And Eric noted this earlier, but when you look at the QMHAR and the QMHPR, those are based off the current organ administrator role qualifications to be QMHA or QMHP. So that's our base level. Our exam extends beyond that with the supervision, or our QMHPC extends beyond that with the supervision and with the exam, and same for the different levels of QMHA 1 and 2. Jamie.
Hey, super quick, can you point me to a definition or maybe I'm overcomplicating it. When you say supervised clinical experience hours, is there a definition, what counts as that, what doesn't count? If I was a student and I was wondering what counts for that and who can supervise me during this, it would be super helpful in a number of places I'm at for me to if you could just point me to your link or something, that'd be awesome.
Yeah, we have those on our website, and those are based on the role delineation analyses performed by NCBBHP, the Centers for Medicaid, and the SAMHSA DSW, Direct Service Worker Competencies, SAMHSA HRSA DSW competencies. So the competencies are posted on our website. and they're an amalgam of those three different role delineation analyses. And again, they're very Medicaid centric.
I think it's a clarifying question, but is it correct that if you're in community mental health, you can be working towards your LPC or your CSWA, but most likely you're practicing as a QMHP or could be practicing. You can either be doing one or the other, or you could be doing both at the same time. Is that correct?
Well, a person with a CSWA or they're an LPC associate, they are a QMHP. The person's a QMHP and they can work in a community mental health program, and they don't need to be registered with us because they're already registered and under a board, and they are enumerated. So you guys probably recall, 10, 20 years ago, Medicaid billing used to be under one number, the agency's Medicaid number. And then the whole system went to individual providers, as Medicaid across the United States is wanting more and more providers to be enumerated and to get rid of the agency enumeration system. So we're not the only state that's doing this. Many states across America are now licensing and certifying and registering undergraduate mental health workers.
Okay. Oh yeah. So basically, we certify non-licensed individuals. The people that we certify are largely restricted to working within COA agencies, certificate of approval. So the agency is licensed by the state. It's likely accessing Medicaid dollars for the services the counselors and peers and whatnot render. And so this is a really good distinction. So unlike licensed professionals, LPCs, LCSWs, MACBO's QMHP credential does not authorize a private practice. It's restricted to working inside of a COA agency. And as Eric was saying, if you're an LPC or you're an LPC intern, you already are a QMHP, just by definition of the rule. What we've done is we've taken the rule and then we've made a QMHP-R that just says, this person meets all the requirements within the rule. And basically now they're up on our registry. They're bound to a code of conduct, because historically you would go from agency to agency and you would get requalified under these rules. And then if you left that agency, the next agency would have to requalify you, and they'd put it on a piece of paper and put it in your file. And when they billed insurance, they'd get it pulled. And part of the reason that we started this process of certification was to have people on a registry to make it easier for billing, but also to hold people accountable to a code of conduct, because people could get fired from their job for some egregious violation and then walk across the street and get hired again. And there was no documentation following this person. So one of the things that we struggle with is we often have people that are registered with these licensing boards, and they don't understand the difference, and they try to register with us, and we say, no, you already are a QMHP. You don't need to come through us. Save your money and your time. But it is a big point of confusion. Let's see.
Well, and a lot of people, they'll get registered with us right away out of graduate school because they want to start working. They want to start working tomorrow, and they don't want to wait 2 months or 3 months. So to get registered with a licensing board. So they'll come through us, and it's really just literally for like 60 to 90 days.
Yeah, it's just a Band-Aid. We're, nothing against the licensing boards. We're just really quick with our automation and some of our processes, and people look at it as a way to sort of fill the gap so that they can enter the workforce while they're waiting on their other applications to be processed. But Jamie, you were asking earlier about who can supervise QMHAs and QMHPs. All of that is defined under the OAR's 309 is what it's defined under. And again, they have to have a clinical supervisor, and that's what prohibits them from opening their own private practice. Is they really only exist inside of a COA agency. If you read the rule, like, you don't get your QMHA and then go work at fast food. because they don't really exist there. It's really only in this one section defined in the 309 outpatient rules. Okay, these are our active credential numbers. A lot of CADCs. You see we have a ton of registrations. So like you look at our CADCRs, we have 28, 36. That's something we spend a lot of time tracking, is these registrants, and we try to see, did they convert? Did they take the exam and move up to a CADC 1 or a QMHA 1? And if not, did they maybe become a peer? Did they get a different certification? We're always trying to track and see, who moves from an R to a 1, from a 1 to a 2 to a 3. And as Eric was saying earlier, we can show in our data that the higher level credential a person has, the more likely we are to retain them. They have a much higher renewal rate. And so just that process of climbing the career ladder and not, having an unreachable goal or capping out as soon as they enter the field is often, what helps them be retained. Oh, Liz.
Sorry, this is like one of the things I've been wanting to ask about. So it said with the QMHP, it was important to keep that as a master's level thing on the last slide. I was wondering, with what you guys were saying about if staff have something to work towards, they're more likely to stay in the workforce. What about like what is beyond QMHAR into QMHP to QMHPs? I know that there has to be some sort of like education and things like that. I ask it because I know we've talked about it a little bit. There used to be a grandfathering in program. Like there's a person who works for Project Respond who's been here for 23 years and she's a QMHA. And she's educating the QMHPs constantly because she's been doing this work for so long. So I just wonder, is there going to be any exploration of growth beyond a QMHAR, or would that always have to be a master's level?
So what's beyond a QMHAR is a QMHA 1 and a QMHA 2. So it sounds like
that's what I meant. A QMHA 2. Sorry, I was looking at the.
Okay, so you're saying, is there going to be something beyond a QMHA 2? Not at this point. I mean, at this point, people are they complain about all the levels that we have. And Liz, you're proposing that we add another one, but we're not against it because we know that it works.
Right.
Yeah.
We know we have the data that shows that the more levels, the more steps that you have in a career ladder, the more likely people are going to stay and be retained and be passionate and be motivated because they have like a goal they can work towards, something that they can work towards. So we're not opposed to adding like another level that maybe has like some additional privileges. We've talked about this in the past in some of the subcommittee meetings in Florida and California. They have QMHAs, they allow them to do what's called preliminary diagnosis. Now, in their states, in Florida and California, the reason that they did that is because they didn't have enough QMHPs to diagnose right out of the gate so that they could begin billable Medicaid services, because historically you had to have a diagnosis in order to start billing. So now, that problem has been somewhat alleviated in Oregon because of the extension that programs now get before a diagnosis is required and their ability to bill prior to the diagnosis. So that problem has kind of been solved, but that's what some other states have done. Taylor?
There, I'm just chiming in with a quick time check that we have about 2 to 5 minutes left for this presentation. So just wanted to flag that for y'all.
Okay, all right. So we're going to fly through this then. Go ahead.
Yeah, just go to the ethics.
Okay. So, we do all the same stuff that most of the boards do. We assess, we do a little bit more work around equivalencies with a lot of our undergraduate certifications. We assess diverse educational histories, assessing training, college transcripts, and equivalencies. This is a lot of work that we do. to ensure that there's adequate cultural representation in the MACBO workforce. So we have a code of conduct. We actually got rid of our code of ethics in 2018, and we moved over to what's called a code of conduct. And it is 13 explicit pages of explicit behavior. It's very concrete. Previously, in the mental health workforce, amongst QMHAs and QMHPs, really the only sort of safety check was APS Otis. And APS Otis really only investigated egregious complaints. So everything that is less than egregious really flew under the radar until just the last 5 years. So between January and July, we received 104 ethics complaints. We're on track to have about 178 ethics complaints for 2025. So it's quite a bit, quite high. We've screened out 32 of the complaints as not applicable because a lot of times it's, like maybe a spouse complaining about their spouse, and it's stuff that's not really relevant to work. It's the complaint they have is not associated with work. We have 31 that are in active screening, 19 in open investigation, 7 closed with no findings, 8 closed with findings, and 7 being held in abeyance. And that might be because they're being investigated by the LPC board or LCSW board or APS Otis or the police or the Department of Justice. This is especially true when it comes to like Medicaid fraud. So MACBO doesn't have forensic accountant investigators, so we don't have the capacity to do financial fraud investigations. So we defer to the Department of Justice on that. So on average, we screen out about 1/3 of complaints. 1/3 are closed with findings and sanctions, and 1/3 are closed with no findings. And that's probably similar to a lot of the other boards. And then this is our last slide. This is just the range of complaints. So about 30% of complaints are dual relationship, sexual or social. 14.5% some sort of workplace misconduct like harassment, policy non-compliance, failure to do documentation, client abandonment, just quitting without notice, client welfare abuse, neglect, adjudication. And most of the adjudications are actually DUI. It's where staff get a DUI. Substance use, some occupational impairment as a result of substance use, breach of confidentiality, competence and scope of practice, and then fraud or regulatory non-compliance.
That's it.
Okay, great job. Thank you so much. This is going to be high level where people are going to have additional questions. This is also opportunities to further discuss or have more questions in your subcommittees, but we wanted to do the overview for everyone because everybody wanted it and needed it. But we can get in more detailed discussion in smaller groups. So thank you very much. Next, we're going to go to the mental health regulatory agency presentation with Todd and is it Lori?
It's Laree.
Laree. Hi, Laree. Nice to meet you. And we'll take, my hope is that if we can, let's go through the whole presentation and then do questions at the end just to make sure you can get through all of it, it's okay that we did it a little differently in the first one, but let's try to do it that way just so we can track the time. And then if people could just hold their questions and we'll do questions at the end.
Great. So can everyone see the screen?
Looks great.
So thank you for having us today. So we're happy to provide some information on sort of how we're structured, what we do, some recent initiatives we've completed or are in process with. I'll be kicking us off today. I'm Laree Stashik, Policy Advisor to MHRA. I've been in this game for a little while, well before MHRA was established in 2018. So I'll start off with our org chart. As Casey explained previously, MHRA oversees 2 boards. We have 17 FTE, which grew from 15 that we had in last biennium. For 2025 to 27, we added 1 new permanent position for each of the compliance and licensing programs. The Board of Licensed Professional Counselors and Therapists has 8 board member positions. Board of Psychology has 9 positions. Our members are appointed by the governor and confirmed by the Senate. MHRA agency staff carry out the direction of the board. So we administer sort of the day-to-day administrative licensing compliance functions through a delegated authority. So board functions. So we have, the boards have 2 main mission-oriented functions, licensing and compliance. So in accordance with state law, the board sets the education, exam, and experience requirements for licensure. The boards adopt and enforce administrative rules and ethical code provisions. Our licensing team processes the applications and then also the license and registration renewals. We conduct audits of education, continuing education compliance, and we respond to a lot of questions about licensing. Our compliance team conducts investigations and presents cases to the board, which then votes on disciplinary action when it finds that violations have occurred. This includes unlicensed practice of the professions as well. Typical sanctions include everything from, like a reprimand or a requirement for somebody to complete additional continuing education, all the way up to additional supervision, license suspension, and sometimes revocation of a license or registration. So this slide shows a breakdown of each board's professions as of year-end 2024. Of the 12,678 total providers we have or had at that time, licensed professional counselors or LPCs, they represent just under half. That's followed by the psychologists and then the licensed marriage and family therapists or LMFTs. Psychologist residents and professional counselor and marriage and family therapist associates, those folks have completed their degrees and they're practicing under supervision as they complete their clinical hours for licensure. And the boards also issue limited permits to licensees from other states for sort of more limited purposes, practice in Oregon. So this chart shows just the licensed providers. Our overall average growth rate has been 7.7% per year over the last decade on average. Counselors and therapists are actually growing more quickly at 9.7%. Psychologists are around 3.1%. So while the Oregon population has grown just over 6% in 10 years, our MHRA licensees have increased by 95%. We now have 1 licensee for every 417 Oregonians versus 1 for every 765 back in 2015. So this shows a high-level summary of how to qualify for licensure for each of our professions. Our psychologists are doctors. Our LPCs and LMFTs are typically licensed at the master's level, but some of them do have doctoral degrees. Once the person earns their degree, including their pre-degree clinical experience, they can apply for licensure with our boards. Once they're approved, they begin working towards the post-degree supervised clinical experience, and then there's 2 exams that we require. The national competency exams are administered by professional organizations, and then the boards administer their online Oregon laws and rules exams. Psychologists complete a minimum of 1 year and 1,500 hours of postdoctoral residency. LPCs and LMFTs complete at least 2 years and 1,500 hours of direct client contact post-degree, up to 1 year and 400 hours of the total 3 years, and 1,900 hours can be completed pre-degree in a practicum and or internship experience. So here's the overview of how the application process generally works. Applicants can start by submitting documents. Even before they apply, they can complete their fingerprinting for the criminal background check up to 90 days before their application is turned in. We collect items like transcripts that show the degree conferral dates, verification of licensure in other states if they have that. And then there's various forms to document clinical experience and other things. The applicant portal is where they complete and submit their application. And then once they submit it, they can log in anytime to check the status. The portal shows a list of the items they need to complete their application file, and our staff go in and mark those items as received as they're coming into the office. Once the file is completed, it's reviewed by our licensing team. They check for sufficiency, and then it can be approved. If the person needs post-degree experience, then that's the point when the registration or residency is issued. Someone that comes in from another state will typically already have met the experience in the competency exam requirement, because those are statewide things, but sometimes they have other requirements, but usually their last step is the laws and rules exam. And then we can issue a license. So this chart shows our growing rate of applications received annually. We actually expect to see over 2,500 applications this year based on our average 12.3% growth that we've seen over the last 5 years. One of our key performance measures that we report to the legislature each year is the average number of calendar days it takes for us to approve a complete application file. Last year in 2024, our licensing team averaged 2 days for both boards. So our growing volume of providers also means more complaints that our boards receive. While the growth over the last 5 years has been high, at an average of 21.7%, since September 2024, we've seen an unprecedented surge in complaints, and this doesn't seem to be slowing down. We're not exactly sure why, but if it continues at this rate, we will end up with 392 investigations this year. That's more than double the volume from just 4 years ago in 2021. So usually our complaint numbers break down to about 65% licensee, 20% applicant, registrant, registered associate complaints, and then 15% unlicensed practice cases. So this slide shows some of the agency-wide initiatives our management team has been working on. In the past few years, we've taken steps towards our goals to improve systems, reduce unnecessary challenges to becoming licensed, promote DEI, and to align our policies and procedures between the boards so that we can help reduce confusion that we've seen both internally and externally. By becoming more efficient, we were actually able to reduce the licensing fees in 2024 for both boards. The diversity study that was completed about 2.5 years ago helped us to identify concerns and areas to explore for improvement. Following that study, each board formed a DEI committee, and we continue to meet monthly to review and make recommendations to their respective boards. And the next couple of slides will show some of those initiatives in a higher level. Customer service improvement, that's actually our #1 strategic goal for our 2024 to 27 MHRA strategic plan. Our recent customer service policy sets a 24-hour response time as our standard. During the 2025 session, we did a lot of work exploring the interjurisdictional practice compacts, kind of looking at the pros and the cons and limitations and so forth. We also implemented Senate Bill 1552 this year, and that's actually a typo in there. It's 1552 rather than 1512. My apologies. That was the earlier bill that didn't pass. This bill passed in the 2024 session. Our work included rulemakings for both boards and integrating these petitions into our system. So now, as of just last week, a person can submit their petition and materials through our online board portals. We've also been more active in recent years in participating in and providing information to work groups that are related to behavioral health so that we can support our partners and other agencies and the legislature and to promote a better understanding of what our boards do. So here are some of the most significant board of psychology specific initiatives over the past few years. Most of these are rulemaking and process changes that have helped to reduce barriers to licensure without compromising public protection. The board has reduced some paperwork burden that we found to be unnecessary. We've clarified and changed some questions related to prior conduct and criminal history. We're in the process of reviewing application-related forms, and we've already completed improvements to several of them. The board is currently accepting public comments for a rulemaking proposal to allow programs accredited by, it's called PCSAS, the Psychological Clinical Science Accreditation System, so that those will qualify for licensure. This is an initiative we're intending to help expand options for psychology students seeking quality programs that will later qualify them for licensure in Oregon. So here are some of our recent Board of Licensed Professional Counselors and Therapists specific initiatives. The reduction in direct clinical experience hours required for licensure was a significant effort and involved thoughtful consideration of feedback from many stakeholders, legislators, licensees, educators, professional associations. That diversity study that we mentioned in the last slide that recommended a reduction to 1,900 hours. So this is actually what the board ended up adopting, and that change became effective on July 1st, 2023. Also in 2023, we added some more flexibility for reciprocity applicants, but then we expanded that even further in 2024 to significantly reduce the paperwork requirements and to waive most of the education and experience requirements that we were previously verifying for those folks that were licensed for at least 3 years in another state. There have been several changes to processes for registered associates. For many years, clinical hours submitted to the board past the due date were automatically denied. We did away with this rule in 2024. We also reduced hours reporting frequency and then tied the supervision reports that they turn into the registrant's annual renewals. So this reduced the reporting burden from 3 times a year to just once, meaning they have less opportunity to miss deadlines, and then that frees them up. They have more time to focus on their important clinical work. So we've also taken steps to improve our presentations that we give to Oregon graduate programs. We continue to try to find ways to better communicate information about licensing, prevent avoidable mistakes during the process, and to make ourselves available and approachable to applicants. Again, our work to become more efficient, along with the continued growth in our licensee base, has actually allowed us to reduce the fees last year. And like our other board of counselors recently revised the character and fitness questions, made improvement to various application-related forms. Our current major project is that we're reviewing educational requirements for unaccredited programs. This is currently in committee, and we expect to have a rulemaking proposal package ready to present to the full board during our next meeting in October. And I think I covered everything on that one. So I'll now pass the baton to Todd for the next slide.
I get the easy slide. And you can probably see why I asked Loree to present this. She has lived these, and she can better speak to the reasoning behind the boards and the hard work. So what can we look forward to for MHRA in the future? A little bit of word salad here I created. We'll continue to solicit feedback, evaluate, and refine our requirements and processes as appropriate. But what that means is we're engaged. Loree, when she's here in the office every Tuesday, a significant amount of our time is spent just discussing what's happened over the past week. What have we heard from interested parties? What are our next steps? What are we working on? A huge part of that, and I failed to put it on this slide here, that's our continuous improvement in customer service. What my observation, I've been here about a year now, my observation has been oftentimes if you provide poor customer service, that eventually turns into a complaint that your requirements are too stringent. If somebody shows up, they either qualify or they don't, but if we take extra months to give them that information, it does not land as well as it does on day one. So we're being very thoughtful in making sure if somebody comes to us and says this is too hard, about weeding out. In a lot of cases, it's just that it took us too long to connect with them and get them the information they needed. So I can't overstress how important the customer service is in ensuring we get this right. And we walk the balance, right? There's a balance between protecting public safety and ensuring we only have the minimum requirements necessary to protect that public safety. So we're constantly walking that. You've seen the 3 E's: education, experience, and exam. Each one of those supports the other. So if you reduce or revise requirements in one, in a lot of ways you're relying on the other 2 to help support that. And that's why we're also careful to make sure we're, again, very thoughtful as we do that. One of the things I did want to bring up, the Talent Council work, at least in my subcommittee, we're working on discussing and trying to establish common terminology, understanding, and strategy. I think that's very important to the work MHRA is going to do. We're one aspect of it. You just saw MacBo's presentation. It strikes me as one of the biggest barriers right now is just we're all lacking that common understanding of the terminology and who's out there. And a quick shout out to the part of our improvement here is going to be a new licensing system. Good service absolutely needs good tools. And we have a current system that requires a lot of manual intervention, which does keep us from using staff skills in the critical thinking areas that we need them. And I think I'll leave it at that. Questions? And Taylor, I see you had your hand up.
You got ahead of me. It was just a friendly time check. Thanks, Todd.
Okay, thanks.
Oh, I do. I guess I have 2 questions. Just if you could speak, what, and I'll try to add these for everybody. Which of your licensees would you say is serving the most Medicaid population? Because we talked about it in the previous. And then could you say a couple things about I think this is the first time fitness and it was introduced. Fitness and I'm sorry, I forget the other word.
Character and fitness?
Yeah, can you just describe that a little bit about what that is? Because I'm not sure everybody has this. Not all of them have the same requirements, so that'd be great to unpack.
Absolutely, we left it off the list, but we have character and fitness as well. It's currently for us, it shows up as background checks. Previously, we also used to require letters of recommendation. We've done away with those. Those appear to be more of a paperwork exercise than an actual impact to the licensing. But for us, it's the background checks. And the boards actually deny very, very, very few license applications based on those background checks. But the couple that I have reviewed that did, it would highlight for you how important it is that we actually do that review. And it's important for me to say that. I know sometimes the background checks are brought up as a barrier. I have found them to be, even though they're impactful in very few cases, they're highly important. And I don't have an answer on Medicaid. I think I would see if Larry has a feeling for the percentage of our licensees who serve Medicaid patients.
I think that's going to be primarily the LPCs and LMFTs, the master's level providers, and also the registered associates, those pre-licensed folks.
Is it more at the associate level, or is there or is it at the PC level? Is there a billing difference?
I'm not exactly sure on the. We're not so savvy with the billing kind of insurance stuff. But I know that OHA was recently surveying and trying to figure out like how many of registered associates are serving Medicaid because the upcoming rule change proposal.
Perfect. I noticed in the HEC talent report, it talks about it was CSWAs specifically around Medicaid. So I just wondered if it was the same, if it was licensed clinical, if it was counseling associates as opposed to that, just because it was called out in the HEC survey. So we can see.
Yeah, I think that survey from OHA will be informative.
Great.
To see how many of the associate level, which are the pre-licensed supervised folks, how many of them are serving Medicaid, and if that change happens, it would be more because they wouldn't qualify for billing outside of a COA site.
Thank you. Yeah.
So it's always been my understanding that LPCs and LCSWs, when working as a QMHP inside of COA agencies, that there's a billing modifier that allows a higher rate of reimbursement, to encourage them to stay inside of COA agencies. So that's always been our understanding of how it works. And Todd, y'all are doing a great job with the customer service, because y'all's application times have really improved.
Thank you, Ben. And in full disclosure, that does measure the time it takes us to approve a completed application. And so in full disclosure, some of our customer service challenges, what it impacts is the time from application submission to achieving that completed application. But our times have also, my observations, been drastically decreased in those areas.
Yeah, definitely.
Taylor.
Yes, just jumping in to note that I do think we are at time, but First Lady, defer to you.
I think if there, I think unless there are any other burning questions, do we want to do, let's see, we should be at are we at our 10-minute break?
Yes, and I think that we can do either a 10-minute break and might have to drop the time a little bit for the next two presentations, or do a 5-minute break.
That was my question. Okay, and this is, I know it's a little hard. I want to see like a show of hands. Would you rather, I know it's always a little hard to do, but I'm trying to figure out if people want a longer break and then just be okay to go a little over, or a shorter break and trying to stay in time. So, wait, see, yes. So, if you want to do longer break, like yeses or this. Shorter break is yeses or this. Okay, shorter. Okay, everybody likes a shorter break. Okay. Do you want to do 5 minutes? Run to the bathroom, grab a glass of water. Okay, it is 3:10. We'll take a 5-minute break and we'll be back at 3:15. Great, thanks so much. All right, great job. Well done. Fantastic. Right, thank you for getting this teed up. This is fantastic.
Okay. Yeah.
Perfect. And we have Ray Miller with the Board of Social Workers. Thank you so much. Thank you so much to everybody today for these presentations. It's really helpful to have for everybody to have a baseline. Just really appreciate the time that you put into this.
Hey, can everyone hear me?
We can.
Okay. Oh, you can hear me?
We can hear you.
Okay, great. Awesome. That's what I was concerned with. And then can you all see the presentation?
Mhm.
Okay, great. Awesome. Okay. I apologize for I'm trying to figure out how to get it to go to where the full screen is the presentation. Uh, yeah, I don't know how to do that. I apologize.
You want do any of our wisdom from the crowd?
Ray, you're so close. Go back up to where draw and design, and right above it, there's like a play. There's like a right above design. There's a right next to that. Yeah.
There we go. Thank you. All
Of
right.
course. We help each other.
Okay.
You're
All right.
learning. I love it.
Collaboration. Awesome. Okay. So my name is Ray Miller. I'm the executive director for the Board of Licensed Social Workers. Today I'm gonna do a presentation to the Behavioral Health Talent Council on kind of a general overview for the Board of Licensed Social Workers. The Board of Licensed Social Workers performs two primary functions. One of those is licensing, the other one is compliance. And in this slide, I'm going to talk about the licensing function for the Board of Licensed Social Workers. Under licensing, the first step in licensing is determine qualification. Oh, and I'm also going to give um, as I go through some of these, if you have some deja vu, the Board of Licensed Social Workers and MHRA operate similarly, and so some of what you'll see here, you might have seen in MHRA's presentation. That's by design. We operate pretty closely. So under licensing, we determine qualifications to practice social work in Oregon, and how we determine qualifications is through education, exams, supervision and experience, and also as MHR they talked about a fitness test. Once the person is determined to have those qualifications, the next step is to issue the license. And then licenses are issued for new applicants. We renew licenses and also issue current licenses. We monitor ongoing continuing education, and then there's also consumer outreach as part of the licensing process. The other high-level function for the Board of Licensed Social Workers is compliance. Compliance has to do with setting and enforcing regulations. The Board of Licensed Social Workers had a code of ethics that every licensee is exposed to and understands. We also, as part of the exam for every licensee, they're exposed to Oregon Revised Statute and also Oregon Administrative Rules so that each licensee understands what compliance looks like and what once they get a license from the Board of Licensed Social Workers, how they're expected to conduct themselves and the statutes and rules that they are required to comply to. The other part of compliance is investigating complaints, and some of the categories under those complaints are unethical or unprofessional conduct, unlicensed practice, and then practicing while impaired. The enforcement actions for the Board of Licensed Social Workers are conducted through review and the vote of the board. So after those complaints are investigated, the board looks at those complaints, does a review of each one, and then the vote of the board determines what actions happen. Those actions can include stipulated agreements, contested case hearings, and also appeals. The Board of Licensed Social Workers, this is going to show the screen if I change it. Give me just a second here. Okay. All right, there we go. Okay. All right, can you all still see this slide? social work license and certification types? Hello? Am I still there?
We can
Yeah,
see.
yes, we can see
Okay,
it.
Oh,
great,
yeah.
awesome. Right. Okay.
We're also diligently on mute. We're such good students.
All right.
But
Okay.
we're with you, Ray.
Okay. So there are four different license types that the Board of Licensed Social Workers does or provides. I'm going to start with the Clinical Social Work Associate license. The reason I'm going to start with the or certificate, the reason I'm going to start with that one is because I think there's a general understanding amongst the mental health population as far as for what the clinical social work associate can or cannot do. The clinical social work associate is a certificate. It is not a standalone license. It is a certificate that is specifically designed to move an associate to licensed clinical social worker. A clinical social work associate works under supervision always, and a clinical social worker associate works in an agency. They also have to have a plan of supervision in place in order to even have a clinical social work associate certificate. A clinical social work associate does not have the flexibility of a licensed clinical social worker. And I get questions all the time as to what a CSWA can or cannot do. And most of those questions apply to what an LCSW can do and what a CSWA is outside of a CSWA scope of practice. Generally, when I get those kinds of questions, the Board of Licensed Social Workers does a really good idea of explaining to a clinical social work associate what is within their scope of practice. And so we also, the Board of Licensed Social Workers gives the responsibility to the clinical social work associate and their supervisor for how to be compliant and to keep that certificate. And so when I get those questions, the clinical social work associate pretty much knows what's in their scope, and they can tell that supervisor or they can tell that organization what they can or cannot do. And what they can't do goes under our next category, which is the licensed clinical social worker. The licensed clinical social worker is the highest level of clinical licensure. It allows independent practice as compared to the clinical social work associate, which does not. It includes assessment and diagnosis, treatment of mental health conditions, and can provide supervision for the clinical social work associate. So those are our clinical licenses. Under non-clinical, the Board of Licensed Social Workers issues the Licensed Master Social Work, which their scope of practice is advanced non-clinical practice. It includes counseling, case management, research, advocacy, and program development, but a licensed master's social worker cannot provide clinical services. And the same thing with the registered baccalaureate social work that is also non-clinical. And the non-clinical licenses are also voluntary. So non-clinical social workers are not required to get a license, but if they choose to get one, these are the categories. Back again to the registered baccalaureate social work. They are a generalist. Their licenses are non-clinical once again, as I explained. The typical roles include case management, community organization, client education, and they cannot provide clinical services. Under our licensing requirements, once again, for the Board of Licensed Social Workers, I'll start with the Clinical Social Work Associate so that the general population understands what a clinical social worker associate can and cannot do. A clinical social worker associate is required to have a master's degree. As I said before, clinical social work associate certificate is not a standalone license. It is specifically designed as a pathway for an associate to receive a licensed clinical social work license. Um, every clinical social work associate has to have a board approved plan of supervision. Every license that the Board of Social Worker provides requires the passage of an Oregon Rules and Laws exam. And then the CSWA requires a background check, and they have to pay the applicable application and associated fees. The other the clinical license that the Board of Licensed Social Workers provide is the LCSW for licensed clinical social worker. They're required to have a master's degree in social work. They're required to have at least 100, after their master's of social work degree, at least 100 supervision hours, at least 3,500 practice hours, and out of that 3,500 practice hours, they're required to have 2,000 direct contact hours. They're also required, like every single licensee, to pass the rules and laws exam, And specific to licensed clinical social workers, there's an ASWB clinical exam that a licensed clinical social worker has to pass in order to qualify for a license in Oregon. And then once again, they pay the application and then the associated fees for that. And then now we are to our voluntary non-clinical licenses. I'll start with the licensed master's social work, and they're required to have a master's degree in social work. Once again, to pass the rules and laws exam, and then the ASWB, that's the Association of Social Work Boards, is what ASWB stands for. Master's exam to complete a background check and also to pay the application associated fees. The registered baccalaureate social work license, they're required to have a bachelor's degree in social work and then pass the Oregon Rules and Laws exam, and then the Association of Social Work Boards bachelor's exam, and then also to have a background check and to pay the application and associated fees. So makeup by state or the makeup of the licenses that the Board of Licensed Social Workers issues by number, the largest, as you can see here, about 75% of all the licenses that the Board of Licensed Social Workers currently has issued, about 7,284 are the licensed clinical social work licenses. And then as you can see in orange, the next largest category, as I said before, is a clinical social work associate certificate, which is once again not a standalone license, simply a path to licensed clinical social work. We have about 20% of our total licensee population that have those, about 1,954. The next category is our licensed master social workers. They're non-clinical and voluntary. We have 368 of those. And then 36 registered baccalaureate social work licenses, 36 of those. And once again, those are voluntary. And for a total of about almost 10,000 licenses. So, and this slide shows the increase in the number of licenses that the Board of Licensed Social Workers has issued between 2014 and 2024, about 10 years. And if you notice, I'm not going to spend a whole lot of time on this one, but in 2014, if you notice, there's about 5,000 licenses that were issued, somewhere around 5,200. And then fast forward 10 years later, we're at 9,300, which is almost, close to 10,000. So that population has doubled almost in that 10 years. So, and kind of wanted to make sure that this population understood that. The next one now, this is something I'm really proud of here. The Board of Licensed Social Worker has 9 total FTE, and we provide services. We serve 9,600 licensees with a population of 9 FTE. Our breakdown is we have one executive director, that's me. We have uh, we have 6 licensing staff for a total of 5 FTE. And then our compliance team, we have 3 FTE on our compliance team. Okay, now I want to talk about application processing for the Board of Licensed Social Workers. So before I go through this slide, I'm going to talk real quickly about the 4 steps that the Board of Licensed Social Workers use to measure how we're processing applications. If you notice, the metric that we use to determine how fast we're processing applications is a little bit different from MHRA because our processes are a little bit different. So step number 1, short and sweet, we ask that the person goes into the portal and follows the instructions. That's step number 1. Step number 2, if they've done that correctly, then our application staff look at the information that they provided and then make sure that what that person provided is everything we need to process that application. If they haven't provided us everything, that's going to result in a delay in application time. If they have, then they move on to the next step. The next step is whatever the person cannot provide, then we wait for those parts that person could not provide at the time of application. I'll talk about that a little later. So that's step number 3. And then step number 4 is actually taking all of that information, processing the application. I'm going to start with the third bullet point. Application processing time for most applications, over 90% of applications, Once that person does step number one, which is follow the instructions in the portal and do what we ask you to do, and then press that submission button. When they press that submission button, for over 90% of that in any application, if they've given us everything we need to process that application, we will have them a license in less than 30 days, in and out. Um, the most important piece of that, we get this question all the time. I'm going to go to the second bullet point. Very important. Application approvals are independent of board meetings. Applicants do not have to wait for board meetings to receive approval. So I'm going to reiterate this one. The Board of Licensed Social Workers does not have to wait for a board meeting to give a person a license. If you give us, once you press that submission button, irregardless of when the next board meeting is, if a person has given us everything we need to process that license, that person will have a license in less than 30 days. This top one I'm going to talk about now. So this, as I stated before, we've got kind of four steps. Step number one, give us what we need. Step number two, we take a look and make sure that the person has given us everything that we need. Step number three, those things that person can give us at that point in time, we wait to come. And then step number four is once we have all of that, within 1 to 10 business days, step number four, we'll have that person their license. And then I'll go to this bottom bullet here. Applications not processed within 30 days are missing one or more of the following action items that are the responsibility of the applicant. And so that's step number three that I was talking about, which is number two, they give us everything. We make sure they're giving us everything, and then we have to wait for the other things to come in. And these are the other things that the applicant needs to give us in order to process that application. These are the things that can cause delays and make them wait more than that 1 to 10 business days to get that license. The fingerprinting and background check, that falls within the realm of the applicant, and that's typically done uh, somewhere around before they press that submission button or shortly thereafter. The transcription requests, and that comes from the universities. I don't have control over that. The applicant doesn't always have control over that, but most of them come in fast enough for us to get them a license in less than 30 days. If they have licenses in another state, there's license verifications that are a requirement of getting a license. If they have experience from another state, we also have to verify that. And then national exam score transfer. So, and that's all. And these are all things that happen after that person presses that submission button. But most of these that applicant has something to do with in order for us to get that to process. So a good example would be if they press the button and then never went to their college and asked for a transcript and told that college to send us that transcript, there's no way we can process that application. So those are some of the, those are the variables that will affect a person's application process. So,
And Ray, just to jump in real quick, I know you've got a couple more slides left. We've only got a couple more minutes. So if you can
oh,
just
okay. All right. I can
make
bounce
sure to
right
get
through real
those
quick.
done, then we'll be good to go.
Okay, sounds good. All right. Out of this slide, we got a whole bunch of stuff here, but here's the thing I want you to focus on. There's a section down here that I'm trying to circle that I hope you can see my cursor. This is 11 days. And as you can see from last year, that last step that I was telling you about, where if we get all the information, we can process that application. In July 24, it took 29 days to go from having everything to process an application. Now, or I'm sorry, to once we get everything in, to move that application from having everything we need to move into process to get an app to get a license. Now we're down to 11 days for that. Doesn't mean anything to the person that's waiting on their license, but it's a huge metric for us. But this is what will guarantee that we can get that person licensed in less than 30 days is once they press that submit button, we can have everything ready to go in 11 days as opposed to 29 days, which will guarantee they'll have a license in less than 30 days. Current workforce challenges are existing as MHR discussed. Our existing license system affects licensees' customer service experience and ability to complete required licensure. If there's one takeaway from all of this, and you've heard, I'm going to beat that drum before, and I know you already know, we need a licensing system more than anything else. The COA requirement may impact workforce in unforeseen ways. That's a whole nother conversation, but it will impact workforce. So, and that's um, a whole nother conversation. Um, there's an influx in telehealth agencies within the past 4 or 5 years prior to my joining, and the board is working hard on updating regulations to make sure that we're keeping up with some of the changes that are occurring in the social work workforce as a result of all the increase in telehealth. And some one of the concerns is, the agencies are either don't understand or don't want to understand the difference between what CSWA is their scope of practice and an LCSW scope of practice. And so what we're noticing is some of these new telehealth agencies are asking CSWAs to do things that are outside of their scope of practice. And we're regularly putting education out there so that the CSWAs aren't in the position to where they're compromising their certificate. Um, I'll just hit on a couple of these real quick due to time. I'll go down here to bullet point number two. We have 24-hour response time on voicemails and the 48-hour response time on emails. In 2022, we were able to answer about 44% of all phone calls, which was, governor's office was hearing about that a lot. And then the voicemails were responded to in over 72 hours if they were responded to at all. And then another thing, as I showed you in that previous slide, I'm going to go down the point to the second to the bottom bullet point here. In August 2023, the average time to get a license to staff to be reviewed was 112 days. Through some internal efficiencies, we've got that down to 11 days, which once again guarantees a person the license in 30 days or less. And yeah, I'm not going to spend a whole lot of time going over that. And now we're at questions. So I apologize for not doing not a great job of time management there, but any questions?
Not seeing any questions, I think we can go ahead and move on to
Okay.
the final presentation. And if anybody thinks of any questions, we can maybe get them at the end, or you can always send them to
Or
staff
you can
and we
email
can
them and we
follow
can
up.
talk about them and come back. Because I was like, I had a couple questions about the non-clinical, but we can talk about that at a different time. So yeah, great job and great progress.
Thank you.
Rachel Pruzak. And then I only need about 5 minutes at the end, if not even that. So you feel free to use as much of the remaining time as you need.
Great. Thank you, First Lady. And thank you, Todd and Ray, for sharing the process improvements we've all been doing at the boards. I'm going to do a little bit of a different presentation. Can you all see my screen? Okay. And are you all still with us all? Hopefully, I have timed myself. I know we have 20 minutes and I will move as quickly and as smoothly as I can. Let me just get myself centered with my
And I
presentation.
appreciate that. Also, I think the Oregon Board of Nursing is our largest in terms of volume,
Yes,
correct?
yeah. So the Oregon State Board of Nursing, I'll kick off, consists of 9 board members. And the board's unwavering commitment is to protect the public by regulating nursing education, licensure, and practice. And to uphold this commitment, the board's supported by 60 staff members and a number that is increasing to 65 following the most recent legislative session to help managing our extensive workload. Because as you can see, is it moving along for you all to see? Okay, great. Because as you can see, yes, we have 130,000 certificate holders and licensees. We have a significant increase, just like the other boards, of our CNAs, our LPNs, our RNs, and our APRNs. And this is the most that we have ever had in history. The rise in nurses and NPs is attributed to Oregon's reputation as an attractive place for nurses to work, and the growth in CNAs may be linked to the removal of barriers that I will discuss lately. And just a quick note, I connected with OHA about workforce data and recently learned that approximately 4% of CNAs transitioned to becoming RNs in the last year. And it's something I want to explore, especially those interested in workforce and the various entry points into our profession. For example, I started as a CNA, became an RN, and then became an FNP. It's super important, just as what was talked about by Van and Eric earlier. Okay, so I'm going to start with the certificates. We certify nursing assistants And they have to complete a board-approved nursing assistant program, and we have 38 programs in Oregon that we regulate. You have to pass the board-approved competency exam and pass a background check. And then our certified medication aides, they are certified nursing assistants who complete a board-approved medication aid training program. There's only 7 of those. And of course, then you have to pass the medication aid test given. The next license type is a
Could I
nurse.
jump in just really
Yeah.
fast? Could you do the full screen view?
Oh, yes.
Just
The
your
thing
slides
that
are
I taught
beautiful and I
Ray.
want
The
to
thing
see
that
them
I
with my
taught
eyes.
Ray how to do.
So we know you have those skills.
Yes, except
Perfect. There we go.
now. Oh my God. Thank you
There
for
you go.
letting me
There.
know. No, thank you
Wait,
for letting me know I was doing that.
you
But
had
the
it
problem,
right and
I
then it
just
went
need
back.
to move something because then I can't see my notes. Sorry, everyone. So let me make this as big as I can. One of the things I was learning when I was watching other presentations is I was having to control my own screen because things were really small. Is that better?
Totally better.
Okay, I'm sorry, everyone, that kind of threw us off. So I'm gonna, can you see the nurse
Yep, looks great.
intern? Am I on nurse intern?
This is certified nursing assistant.
There we
There we
go.
go. No nurse intern.
All right. So we regulate the nurse intern license, and to obtain this license, a nursing student provides verification they completed at least one academic term of a nursing education program and included a course with a direct care component of nursing practice. They submit verification of good academic standing and pass the certified nursing assistant exam. There's no cost for this license, and I'm going to highlight this license a little bit further as well. And is it still big enough for you all the way it is? Okay, great. So the licensed practical nurse, they must complete a board-approved LPN program. There's 12 of those in Oregon, and they take the NCLEX PN exam, and they complete a background check. I just want to point out for the council, since we talk about supervision often, that the LPN's practice occurs in clinical direction of an RN's plan of care, or a licensed independent practice like an NP or physician treatment plan, and not under an RN's license. Okay, moving on to the registered nurse. So we have 2 ways to become a registered nurse. We have the associate's degree, which is a 2-year degree at community colleges focused on the necessary nursing skills and knowledge to become a registered nurse. There's 18 of those in Oregon. And then the bachelor's degree, which is the 4-year degree typically at a university where the nursing curriculum includes more courses in science, research, and leadership. And there's 14. To obtain a license in both, you have to complete a board-approved ADN or BSN program, take and pass the NCLEX RN test, and complete a background check. I thought important for this group, since we talk about barriers, is I wanted to highlight a spirited debate that took place in the 2023 legislative session regarding the ability for community colleges to offer Bachelor of Science in Nursing degrees. And with that law taking effect, I want to elevate that while the Board of Nursing approves and regulates all pre-licensure programs, and since associate degree and nursing programs are already approved by OSBN, it's now up to the Higher Education Coordinating Commission to approve the request for these community colleges to offer BSNs. I haven't received a recent update, but I know several community colleges are on track to implementing this. And I definitely suggest for anybody interested is tracking the SB 523 from 2023. It was an interesting conversation around it not producing maybe more nurses, but producing more bachelor's approved nurses, which is a thing that hospitals kind of move towards hiring for different reasons that I won't get into for this presentation. But I think it's an important one for potentially this council to track. Okay, moving on to our advanced practice registered nurses. So An advanced practice registered nurse license, there's a couple of different times. We have kinds, excuse me. We have a clinical nurse specialist, a registered nurse anesthetist, and then the nurse practitioner. And with the nurse practitioner specialty, there are many tracks one can take. For example, there's family, there's women's health, there's certified nurse midwife, and of course the psychiatric mental health NP that I know this group is most interested in. There are only 3 Oregon programs that offer APRN curriculum, and only OHSU offers the PMHNP track. And as shown in the chat when I kicked off the presentation, there's currently 2,356 psychiatric mental health nurse practitioners licensed in Oregon. And to obtain an APRN license, you already hold an RN license, you complete a master's degree or doctorate degree in nursing, and you provide verification of the national certification in what your focus is, and of course, the background check. So I wanted to share that the Oregon State Board of Nursing connects with and partners with the Oregon Center of Nursing often, and we focus on workforce. And I wanted to highlight a link on their website, which basically shows all the nursing education programs in our state, all the offerings that we have. Okay, moving into endorsement. I think on all the other slides you saw where I wrote out-of-state endorsement process, reciprocity on each slide. And I'm aware of including this because that interests this council. I've heard equivalency, reciprocity. So I just wanted to share that we are efficient in handling this process because most registered nurses in Oregon obtain their license through endorsement and often NPs. And that is because kind of the limited amount of schools we have, but the large amount of nurses we have. So for the endorsement process, whatever license, whatever certificate is, you submit an application and payment. You submit a verification of the license or certificate in another state. You complete another background check, and you show proof of education through a transcript or a certificate. And then lastly, on the slides about how we license is sharing the kind of process that was created for exceptions. So we in the legislature wanted to address 90-day exceptions for temporary staffing shortages because during the COVID pandemic, the Oregon State Board of Nursing was taking several months to process licensees. And in response, I was a state representative at the time and led on a law for a 90-day exception. And the law allows an employer to vouch for the nurse they hired without the OSBN completing the necessary steps to approve the application. So reviewing everything and reviewing a background check. So these exceptions are available for non-resident nurses in a single assignment, and to qualify, the nurse must have an application on file with the board. It's just not all the steps are completed. And after the 90-day initial exemption, they can actually apply for additional, but we don't see that happening anymore. And actually, the stats indicate that the exception isn't at all frequently utilized, never mind the extension, because just like Ray and Todd pointed out, we've become very efficient. And right now, once the application is complete, we're processing them within 3 days. But when we first started this in March 2022, there was 1,618 granted in that year. And right now in 2025, we have only granted 175 exceptions. And really, most likely, those exceptions for systems preparing for a strike, as the law states that once the strike's announced, exceptions will not be granted. So that's how we have approached kind of endorsements and exceptions. So now I really want to dig into the main thing that I'm excited for to present here. But when I arrived to the board, I shared my belief with all the staff and the board members and collaborative partners that while there are guardrails to protect the public, I wanted to hear from everyone about what guardrails were viewed, excuse me, as barriers that lacked justification for the public protection. And I know we're really trying to think about that in this council. So after months of listening and an extensive review of our statutes and rules, we discovered some answers. And so in this second half of my presentation, I want to share examples of how we convened RACs comprised of statewide partners to lead efforts in updating rules and removing unnecessary obstacles, two examples demonstrate changes solely made through rule modifications, while one did begin in the legislature through statute. And one example highlights an update to certificate in Oregon, where we were the outlier from all other states. And then lastly, an example will illustrate the creation of a new license type, and then discuss removing barriers within nursing education. And again, my hope is one of these examples inspires a thought or plants a seed for those of us on the council or anybody engaged in it. So moving into rules outlined in OAR Chapter 851, which establishes an approval process for certified nursing programs that meet the board standards and set forth the standards related to curriculum and the certificate of nursing assistants. So as you can see, it was a journey to update the curriculum, and it was concluded, let's see, in 2022 we started because CNAs, I might have been one of those legislators, CNAs and legislators mentioned these barriers, just like we're hearing barriers in this group. So this led to the board hosting public listening sessions, which initiated a review of the nursing assistant curriculum by a dedicated task force. And ultimately, it resulted in the board approving an updated curriculum that reduced the required training hours from 155 to 105, which again is more in line with other states. One point I wanted to highlight, because it's another thing we talk about, is long-term care facilities across our state right now are actually paying for community members to receive this training. They are paying them to take the course because they know they can't take a month off from work to take it. So while they're taking the course, of course, there's some retention goals in there, but there's actually nobody saying you must work here after getting the training. So I think it's something that this council can think about too. So after the curriculum was updated and that journey ended, the process of consolidation began. So this was another year-long effort that culminated in the adoption of the consolidation of CNA 1 and CNA 2 into a single CNA designation, again, aligning with every other state. So we did have a 12-month transition period so that the training programs that were offering CNA 2s and healthcare systems could adequately have the time to prepare for the official consolidation. But it was effective on July 1st, 2025. And moving on, for our rules that establish approval for nursing programs that meet the board standards and set forth the standards related to curriculum and faculty. All right, couple slides on what we did for removing barriers in education for you educators on the call. So OSBN staff and RAC were assigned the responsibility of eliminating unnecessary barriers for nursing education programs while still prioritizing public protection. And in the end, we simplified the process for approving new programs. We removed obstacles related to reporting and approvals for education programs. We updated qualifications for faculty and administrators, and we increased flexibility regarding clinical experience. And I will say, go back up. What is happening? I'm used to presenting in Teams. There we go. Nope. Okay, I think I'm right on track again. So the new program approval process is the first thing I'm going to highlight. And so previously it was 5 steps requiring institutions to initiate the process well over a year in advance. And this has been simplified now to 3 steps based on recommendations from the National Council State Board of Nursing. So all executive officers across the state for all boards of nursing are part of the National Council State Board of Nursing. And it's who I survey when we're looking to make changes at the state level. So the first step is the preliminary development application where an institution has to demonstrate the need for a new nursing program. And the second state is the initial approval for admission of students, and the third and final step is full approval, and it actually occurs after the new program's been graduating its first cohort, allowing the board to really evaluate the program's quality and safety during operation. So moving into nurse faculty, this was real interesting. This whole process was interesting for those of you in education. A rule advisory committee full of deans and directors was really challenging, but after a year, we got there. So we revised our faculty qualifications to align with regional and national trends, specifically limitations around specific number of years of full-time direct care. And I'm going to start to move along a little faster given time, and won't speak to everything. But really, what we needed to do is not be so prescriptive, and instead, the language became academically and experientially qualified for their teaching assignments. I had to address my own bias when going through this, but we don't have time to talk about that. But it's just really interesting going through these processes and what you think is academically and experientially qualified and how prescriptive it was, but what it should be. Additionally, we clarified the guidelines regarding the ability to conduct clinicals in various settings and not just hospitals. I think that's really important for this group too. So moving into that, lastly, about the education program for clinical placements, because this is the battle all day, every day in nursing education, and I'm sure for all of you in behavioral health. So we clarified in our rules that clinical experience can take place in any setting. We eliminated a one-on-one final practicum. Of course, a school can still choose to do that, but we're not going to regulate it. And we increased our time for simulation, but we're really hoping that this is going to allow people to use spaces outside of that hospital setting. It was never specifically stated you couldn't, but there's just that belief that that's where you get your training, and that's just not the case. So this slide is all about the timeline, of course. It's extensive, just like all the other ones I mentioned, so I won't get into the details of it, and instead jump into one of my favorite topics to talk about is the nurse intern. So we did require a statute update for this one, and I was the nurse legislator who led on this. But I took up this initiative during the pandemic after observing the success of the student nurse intern role in Washington and Idaho. And I know our staff is looking at other states for us. But nurse interns not only help address the workforce challenges, but they're gaining experience while students and also earning money. So while I played a key role in passing the bill, I got to the board in this new role I'm in now. And really, the rules that were implemented created barriers. And so I think it's really crucial for us in this group to closely examine the rules and statutes impacting our behavioral workforce, because the discrepancies in interpretation created barriers that the law never intended to. With that, during the listening sessions, I heard loud and clear from the deans of programs and nurse managers of hospitals that they weren't able to implement it. And a common complaint was regarding the duration of the intern license. Previously, it expired 30 days after an academic term and not allowing nurses to work during the summer break. So we updated that to be 12 months, and the simple, straightforward adjustments made a significant impact. I'm going to briefly speak to, and then I get to my last slide, a program in rural Oregon that had successful implementation of the nurse intern. And I'm elevating them because of their leadership and as pioneers of introducing the role in the state. I'm hoping we all think about who's going to do that in this group. But we're now witnessing their nurse interns graduate and transition directly into the nurse residency program. And we know in this group that the transitions is one of the things that doesn't keep us to retain our workforce from burnout. So I think these are those things to think about as those transitions and retention. And from Sky Lake's leadership and those rules and barriers being removed, we're going to see a lot more programs implemented. And I just want to close by saying that the Oregon State Board of Nursing is prioritizing nurse wellness as a fundamental aspect of public protection. This is a really big deal. So over the past 2 years, our efforts have focused on removing the stigmatizing mental health questions from applications, ensuring that licensees have access to the Oregon Wellness Program, and re-engaging in the alternative discipline. And it's important because just like our patients face mental health and diagnoses and substance use disorders, so do we as the healthcare providers. So thank you for giving me the time.
Fantastic. Thank you. Thank you so much, everyone. Great job. Yeah, to have all of these boards do presentations and be able to land on time or close to on time is really incredible. Thank you for speeding up, slowing down, but then still being able to get all the information out there. People are doing really exciting work and have been making a lot of progress. I'm having a little bit of my brain's kind of exploding about ideas and questions. I bet you are too. I'm going to ask you before you go off to your next thing, if you have a few minutes, to please write it down. I want your thoughts. I want the questions, and we can figure out where else, where those conversations happen. Some of them in your subcommittee, some are the committees of some of our bigger committees. Our full town council could be a way to do it. I just want to make sure you capture it before people are off to their next thing if you just have a few minutes. I want to thank you so much. Again, the presentations were wonderful. Thanks for hanging in. I know it's a lot of listening, but this is our workforce. These are the organizations and the people that are bringing the workforce. And so taking the time today with them was so worthwhile. All I really have for you is just two things. When the next meeting is, which is August 28th. And the other thing, I just want to make sure that folks, August 28th at 2 to 4. Okay, double checking. You got to check your paper. August 28th from 2 to 4. And then, as I mentioned earlier, I've been going around and talking with folks. After the August meeting, we are hoping, many of you have been asked, also you're doing some really innovative, exciting stuff in your organizations. And we're just looking for if people have folks that they want to highlight that are doing innovative practices that relate to the Talent Council recommendations, which they almost always do. If they're innovative, they're reducing some barrier, and to call for submissions on that. If there are folks that are doing integrative work that you want to lift up and then can be best practice that we all learn from. I feel like today was a good example of watching people. It's like, I'm doing this, we're doing this, and having an opportunity just to talk about different practices and how we can learn from each other. And then we can, and also those can come out in the final report. So those are just the two things. Next board meeting, and then if people can start thinking about if best practices they want to recommend. And write down any thoughts or notes or questions you might have today that you want to make sure that get brought back up at a later time. Other than that, thank you so much. I deeply appreciate you and your time today and the work that you're doing to help us impact the workforce crisis.
Thank you.